bone marrow transplant at Institute of Blood Disorder. We welcome you in this fifth episode of Innovations in Hematology. And today's topic is acute GVHD, which is a nightmare for all the physicians. Somebody has used ATG upfront, somebody has used abatacept upfront, but still acute GVHD evades us into a clinical practices and creates a problem for the patients as well, still leading to deaths in many of the patients undergoing a bone marrow transplant. So it's still an unconquered frontier. And today, to understand this, we have the renowned faculty from MD Anderson, Amin Alusi, and Dr. Uday Popat, who will be making us understand through going through these challenging situations in acute GVHD. To conduct this, we have Dr. Nikhil, who is our lead specialist, who will take care of the proceedings from here on. And he has a few slides, one slides to show our approach at Department of Hematology at Fortis Gurugram. We welcome you all for this academic feast, and I'm hopefully that after 1 hour we'll be more sensible and enlightened to how to treat acute GVHD. Over to Dr. Nikhil.
Thank you, Dr. Bhargav. Is my screen visible?
Yes, sir.
Yeah, so we welcome you all for this Innovations in Hematology webinar series. Today, we have a webinar on challenging situations in acute GVHD. And we have two prominent speakers from MD Anderson joining us for this, Dr. Uday Popat and Dr. Amin. Dr. Uday is a professor of medicine, Department of Stem Cell Transplantation and Cellular Therapy, University of Texas, MD Anderson Cancer Center. I invite Dr. Uday to introduce the main speaker for the day, Dr. Amin Alousi.
So thank you, Dr. Nikhil, and thank you, Dr. Bhargav, for that very kind introduction. When I was asked to give this talk, I said, okay, I'll go ahead and talk about graft versus host disease. And then I got a series of questions that Dr. Nikhil sent me that all of you had. And what I realized was I did not know very much about all those questions. This was about what to do in steroid refractory and ruxolitinib refractory GVHD. There isn't much data out there. So then how do you handle this? And I thought you really needed an expert to tell you and distill from whatever little data and world of experience that he has to teach you about what to do in this sort of situation. And the best person is my colleague, Amin Alousi. He's a great friend. And he, on a day's notice, agreed to do this talk, spent whole of yesterday preparing the talk. And I'm so grateful to you, Amin. Uh, he leads our graft versus host disease research effort, and he runs a stellar graft versus host disease clinic. So if you're here in Texas, it would be worth seeing him. And he has led all our studies from MD Anderson, many of the study of the national BMT CTN group. And over to you, Amin. We all look forward to hearing from you.
Thank you so much.
Dr.
Okay.
Amin. Yeah, before I
Yeah.
hand over the section to Dr. Amin, I would like to briefly tell the audience what our approach at Fortis Institute of Blood Disorders, Gurgaon is. So any patient presenting with acute GVHD, we start injection methylprednisolone 1 mg per kg for upper gut GVHD and 2 milligram per kg for lower gut GVHD. We do not wait for 4 to 5 days on methylprednisolone if there is no reduction in the stool volume or frequency, or if there is progression of symptoms. Even after 3 doses, we add on ruxolitinib. And if patient is not responding to a combination of steroids with ruxolitinib in the first week to 10 days, our choice of third line treatment is etanercept along with ECP. While we use FMT and mesenchymal stem cells as adjuvant therapies, vedolizumab has been a useful agent for us, especially in patients who are refractory to all the above mentioned lines of therapy. It would be really interesting to know from Dr. Amin what his practice is and what is the evidence supporting it. He is one of the pioneers in the field of GVHD. Before I hand it over to him, I would also like to inform the audience regarding our next session. This is also a webinar which is very relevant for transplant physicians, where Dr. Medad Askar would be speaking to us on post-transplant chimerism and what the physician should know about interpretation of the same for making informed treatment decisions. So over to you, Dr. Amin. I'll stop
Thank you.
sharing my screen.
Okay, thank you. I'm going to share my screen. And as I'm doing that, I want to thank you all for inviting me and thank my dear friend and distinguished colleague, Uday Popat, for his kind introduction. Let me make sure I get the right screen up. Share. Okay, can you see the slides okay?
Yeah,
Yes.
your slides are visible.
Okay, perfect. So as I understood, the topics that you would like me to review today is mainly on the treatment of steroid refractory and ruxolitinib refractory acute GVHD. And I think before we jump into it, I have a slide with my disclosures. There we go. My main objectives from today's lecture is to review with you the data with regard to ruxolitinib and steroid refractory acute GVHD. Hopefully I can make the case that the best way to treat this is to prevent it, and I'll show a couple slides on that. And I'll lay out definitions around what steroid refractory and ruxolitinib refractory GVHD is and what the evidence may be for that. Of course, I'll review the REACH 1 and 2 data given support for the use of ruxolitinib. I'll review some clinical pearls I've developed over the years in the treatment of this disease population. And I'll briefly cover some exciting areas of research with regard to tissue repair and the biome, mainly in patients with steroid refractory gut GVHD. I'm hoping to have about a good solid 15 to 20 minutes to review the questions that you provided in advance of today's lecture. I'll give a cursory response to those questions, but later I'll forward along to Nikhil, and which you can forward on to all on this call this morning. All the slides that I have addressing the questions, as well as the important and relevant papers. So how do I treat steroid refractory or ruxolitinib refractory acute GVHD? I think the best way to start is to look at the impact of this disease, this complication of transplant. With regard to steroid refractory acute GVHD, patients who meet this definition have a twofold higher risk of non-relapse mortality, approaching 40% at 6 months. And patients who are resistant to further lines of treatment with ruxolitinib do particularly poorly, with non-relapse mortality that approaches 80%. At day 100 and a median survival of just 1 month. I would contend that while I've spent a great deal of my practice and research in the treatment of these patients, patients here at MD Anderson with ruxo refractory GVHD do equally poor as I'm sure those patients do in India. And I don't have any magic sauce to still upon you on how we can further improve the patients with very poor prognosis. So how do I treat steroid refractory or ruxolitinib refractory acute GVHD? Well, number one, I try to at all costs prevent my patients from getting this disease. It's an ounce of prevention is worth its weight in gold, as they say. And how do we prevent this? Well, certainly we have thoughtful consideration of who the donors are and have a team to look at optimizing donors. We take into consideration graft source. I'm sorry, someone, if I hear a little background, if you don't mind muting yourself. So we pay attention to graft source, and in high-risk patients, consider marrow over peripheral blood. But importantly, GVHD prophylaxis is the mainstay for preventing patients from developing high-risk acute GVHD, including steroid refractory. For the dawn of time here at MD Anderson, our standard of care for preventing acute GVHD was with the use of Tacro and many methotrexate. And in match-related donor transplants, similar to what's done in Europe, we would historically give low-dose rapid ATG. In 2013, 14, 15, we began to adopt the post-transplant cyclophosphamide platform, where it's post-given on days 3 and 4 in combination with tacrolimus, with or without mycophenolate. Here we see in the slide results of just about 1,000 transplants between 2015 and 2020. And what we see that patients received post-transplant cyclophosphamide with chaperone with or without mycophenolate had much improved GVHD relapse-free survival. So this composite endpoints looks at patients are free from grade 3 to 4 acute GVHD, chronic GVHD requiring immunosuppressive therapy. They have to be in remission and they have to be alive. And Griffiths is significantly better in patients who receive POSI versus our historical attack methotrexate with ATG and MUDs. Importantly, at least for the MUD group, this was mainly driven not through a reduction in acute or chronic GVHD, but lower non-relapse mortality with POSI, mainly from less infections, especially viral infections, than when ATG was employed. In the MAT sibling cohort, where we historically would give attack and methotrexate by itself, POSI indeed lowered chronic GVHD and chronic GVHD requiring immunosuppressive therapy, but had comparable rates of mitigation against acute GVHD and non-relapse mortality. Um, as those who received the standard of care methotrexate alone. There was really no downside to given POSI. Here we see relapse rates are identical whether we used our historical approach or POSI, and but Griffiths-free survival was markedly better. Of course, this was further supported in our multi-center BMT CTN 1703 trial, which was recently published in the New England Journal of Medicine. Here was a randomized phase 3 trial for recipients of matched sibling and unrelated donor transplants getting peripheral blood grafts following reduced intensity conditioning, and patients were randomized to either post-transplant Cy plus tacro and mycophenolate versus tac methotrexate alone. And once again, Griffiths was much better for patients who received POSI, and this was mainly due to less acute GVHD. Grade 3 to 4, less grade 3 to 4 acute GVHD, 6 versus 15%, and less chronic GVHD requiring suppressive therapy. What are some clinical perils for preventing steroid refractory acute GVHD? Well, I would really make the strong case that as an institution, you should really have well-written SOPs for the work of an evaluation of patients with suspected acute GVHD. Importantly, you should make the case for prompt diagnosis and treatment of these patients, especially those who present with high-risk manifestations, diarrhea, severe abdominal pain, and we never delay the start of treatment for workup. If a patient is post-allo and unless it's very obvious to be something else, you assume that their diarrhea is from GVHD and you start high-dose steroids while further evaluating these patients. We follow our patients very closely, especially when we're tapering them off of prophylaxis, immunosuppressive prophylaxis, and following donor lymphocyte infusions, and we promptly intervene in those patients who present with manifestations. But despite doing everything, roughly 5 to 10% of patients will go on to develop steroid refractory acute GVHD, and that's going to be the bulk of what we're talking about today. So for starters, how do we know if our patients have steroid refractory acute GVHD? Well, the standard definition that has been employed since dawn was patients who had progression of organ stage after 3 days of high-dose steroids at 2 milligrams per kilogram per day would be considered steroid refractory, as would those who failed to improve after 7 to 10 days. And patients who have a flare after initial response following tapering of steroids below some specified dose, say 0.5 milligram or 1 milligram per kilogram per day, could also be considered steroid refractory or better defined as steroid dependent. But where did this definition come from? Is there any validity to this? Has it ever been extensively studied? Well, forever, the answer was no. This was just expert consensus opinion. But in 2017, 2018, the MAGIC Acute GVHD Consortium, which we participate with, looked at this question, and they took all patients within the registry, the acute GVHD registry, who had new onset acute GVHD requiring treatment. And so all patients who met definition of having new onset acute GVHD and got started on therapy. And using the definitions that I laid out on the previous slide, roughly half the patients had a response to steroids by day 7, and half the patients either had progression of organ stage after 3 days or no response by day 7 and would meet the definition of steroid refractory. And in fact, the data suggests that this definition does have merit. In fact, patients who meet the above criteria for being sensitive or resistant behave much differently. Non-relapse mortality is better than twofold higher, approaching 40% at 6 months for those who are labeled as steroid refractory or meet the definition of steroid refractory. Overall survival is worse for those patients as well, and the likelihood at day 28 for these patients to have responsive GVHD is much different as well. So that was important and validated definition, but importantly, the MAGIC Consortium went on and delved a little deeper into this population of so-called steroid refractory patients. And so they took that population, again, roughly half the patients who met the definition of steroid refractory, and they drew serum plasma biomarkers, which had previously been validated in the upfront setting for acute GVHD, that's SE2 and REG3 alpha, and they drew it at day 7 at the point where they would be labeled as refractory or not. And what they found was very interesting. Roughly half to maybe as high as 72% of patients, depending whether they're in their initial or validation cohorts, came back with a biomarker panel that was in fact quite low. And the other roughly half patients came back with a biomarker panel that was high and would correlate with high risk disease. And if you look at the outcomes based on the biomarkers at day 7, you see that those patients who had low biomarkers on day 7, ST2 of reg3 alpha, they had very low non-relapse mortality and really did not differ from those who were labeled as steroid responsive based on that definition. Whereas those who had high biomarker panels had extremely high non-relapse mortality and clearly behaved much differently. So what does this tell us? Well, in fact, using that definition, it's not a perfect definition, and maybe as much as half the patients we label as steroid resistant are truly not resistant, but more better considered what I like to call slow responders. They haven't achieved their response yet using that standard definition, and maybe half are truly steroid resistant. So what do we do with this data? Well, it's important when reading manuscripts and interpreting results of clinical trials for steroid refractory acute GVHD. We want to look at the definition of steroid refractory that's being employed in those trials. We want to look at the median time from start of steroids to second line therapy, because this will tell you how many of these patients were truly steroid refractory, and results can vary quite markedly across these studies based on those factors. It's also important clinically with respect to steroids. Skin normally responds quicker to the lower GI and liver, and those populations A7 may be less predictive. I found it very interesting to see that you consider your patients refractory after just 3 days of steroids and start ruxolitinib. I think that's worth further discussion, and maybe if time allows, we can discuss why you do that and the pros and cons maybe to that approach. A sizable portion of ultimate responders may take longer than 7 days to get better, and perhaps biomarkers at day 7 can further stratify these populations. So what about the treatment of steroid refractory acute GVHD? Is ruxolitinib the standard of care? Well, based on the REACH 1 and 2 trials, we would say yes. The REACH 1 trial was the multi-center phase 2 trial published in Blood, first author Madan Jagazi, 2020. Patients were 12 years or older, had grade 2 to 4 corticoid refractory acute GVHD based on MAGIC criteria. Majority of the patients had failed steroids. A small percentage of the patients had received one-line of therapy beyond steroids. These patients received continuation of high-dose steroids in combination with initially ruxolitinib 5 milligrams twice daily, with the dose escalated to 10 milligrams twice daily pretty quickly if in the absence of cytopenias. Ruxo was continued in treatment until treatment failure, unacceptable toxicity, or death, and the primary endpoint of this trial was day 28 overall response. Here we see the patient characteristics. While patients 12 years older could participate, there were no patients on this phase 2 trial, less than 18. Median age was 58 years. About 20% of the patients were over the age of 65. There was a third of the patients who had grade 2 acute GVHD. The remainder had grade 3 or 4 acute GVHD. Median time from steroid initiation, again, a very important patient characteristic to look at, was 15 days, with the range being 3 to 285 days since diagnosis and start of steroids. About a third of the patients had progressive acute GVHD definition, where they progressed after 3 days. 40% met definition by no response by day 7. And again, the majority of the patients had received just steroids prior to receiving ruxolitinib. Here we see the overall response rate on REACH 1 was just better than 50%. Taking response at any time point, overall response at any time point, 73% of patients achieved a response, including better than half having a complete response. The median time to response was 7 days, and predictors for response in multivariate was limited to just patients' initial presenting grade at the time of enrollment. Patients who had grade 2 steroid refractory acute GVHD did much better than those who had grade 3 or 4, not surprisingly. In terms of predictors of overall response, included whether they responded to ruxolitinib or not, the acute GVHD grade and the duration of steroid exposure prior to enrollment were also predictors. Here we see the outcomes with regard to overall survival and non-relapse mortality. Those who responded do markedly better than those who were refractory to ruxolitinib. Again, the median survival is just 28 days for Rux failure patients, and non-relapse mortality is better than 80%. REACH 2 was the international randomized phase 3 trial of ruxolitinib versus best available therapy. Similar eligibility criteria as in REACH 1, except that they could only receive steroids. And again, the primary endpoint similar to REACH 1 is overall response at day 28. Here were the acceptable best available therapies that centers could pick from: ATG, ECT, mesenchymal stem cells, low-dose methotrexate, mycophenolate, Emcure inhibitors, etanercept, and infliximab. Patient population and responses based on acute GVHD grade. 75% of the patients at time of enrollment who had received ruxolitinib and grade 2 acute GVHD responded, and this was better than the 50% of best available therapy. But importantly, ruxolitinib outperformed best available therapy, even in those with grade 3 to 4 acute GVHD, better than 50% response rate for day 28 versus roughly 25 to 30% in those patients with grade 3 to 4 who received best available therapy. So the day 28 overall response, the primary endpoint, was markedly better for patients who were randomized to ruxolitinib, 60% versus 40%. But somewhat disappointingly, the durable overall response at day 56 was just 40% for the Rux arm. This was better than best available therapy, but room for improvement is certainly needed. The duration of failure-free survival shown in the panel to the right. You have to be cautious with interpreting these results because these patients could cross over to receive ruxolitinib, and you see an artificial steep fall in the orange curve because patients crossed over based on design, and so you have to be cautious interpreting the failure for survival as based on the design of the trial. In terms of safety of ruxolitinib, this is important because we're comparing it to best available therapy, and we're able to compare toxicities across treatment arms. And there were signals, not surprisingly, that anemia was worse for those who were randomized to ruxolitinib versus best available therapy, maybe thrombocytopenia as well. But overall, grade 3 and higher adverse events didn't differ between the two arms. CMV didn't infections or viremia didn't differ between the two arms, and the drug seemed fairly well tolerated. Again, disappointingly, non-relapse mortality at 18 months did not differ between those randomized to best available therapy versus Rux, but median overall survival did favor ruxolitinib at 11 months versus 6.5 best available therapy. So for all practical purposes, ruxolitinib should be considered the standard care for refractory acute GVHD. However, durable day 56 remission rate of 40% is discouraging, as is the lack of reduction in non-relapse mortality, and better therapies are still needed, which is the area of our active research. So how do I treat steroid refractory ruxolitinib refractory acute GVHD? Here's just some clinical pearls. Number one, we do not continue therapies that are not working, and I'll dive into a little bit of how long I continue ruxolitinib in the question and answer session at the end. We have institutional taper plans for tapering of steroids, including tapering of steroids in patients to deem steroid refractory. Number three, if the gut is working and the patient doesn't have ileus, we strongly encourage continuation of enteral nutrition. We don't believe, and there's some limited data to support this, that gut rest is beneficial for patients with acute GVHD at the lower GI tract, again, in the absence of ileus. I caution the use of anti-motility agents and pain medications. The combination of those two patients with advanced lower stage GI GVHD, these patients are very prone to development of ileus and get there quicker with patients requiring narcotics as well, and are also receiving anti-motility agents. We pride ourselves in using a multidisciplinary approach to these patients. We involve physical therapy, nutrition, and others. We do intensive infection monitoring, which I'll review a little bit in question and answer, and we give prophylaxis and promptly treat infections as they occur. Importantly, just like when treating cancer, you do need to recognize when palliative care should be considered, and those patients who have very poor performance status, multi-line resistant GVHD, advanced stage multi-organ dysfunction, concurrent severe infections, and active leukemia, really disease palliation as opposed to ongoing treatment should be considered. So the majority of patients with steroid refractory acute GVHD have lower GI involvement. We've improved over the years where we've seen lower rates of grade 3 to 4, lower GI GVHD, but still with regard to acute GVHD mortality, 80% will occur in patients with lower GI GVHD. And this is really the population where most research is needed in terms of improving outcomes. In a few moments, for the next few moments, I want to review a question that's commonly asked to me. So how do patients with steroid refractory, typically GI GVHD, get better? Is it through the use of immune suppression therapy, or should we be instead looking at tissue repair and tissue regeneration? Importantly, certainly the backbone of treatment of acute GVHD has been immune suppressive agents over the years. Active area of research is looking into tissue repair and regeneration as well as targeting the GI microbiome. But it is artificial to separate these three because the GI tract, as I'll lay out in the next few slides, these processes are all interrelated. There really are not distinct pathways for treatment, and the next few slides will elucidate that further. So what is the biology of the GI epithelium and the stem cell GI compartment? Well, for starters, the GI tract is the second largest epithelium in the body, and it separates the host from the external environment. The GI tract has been called the largest immune organ in the body, and the intestinal epithelium is in direct contact with the content of the lumen, and it must both serve as a barrier function as well as allow nutritional absorption. It's under persistent assault from the luminal content, so this requires epithelial renewal to maintain barrier integrity, and this process is dependent on the proliferation and differentiation of the intestinal stem cell. Rapid turnover of the GI epithelium depends on the active proliferation and differentiation of the intestinal stem cells, and the base of the crypt, at the base of the crypt resides the intestinal stem cell, which also is referred to as the crypt base columnar cell, or the CBC, and you can only identify these stem cells based on the presence of the Wnt target gene LGR5. So LGR5 columnar base cells can give rise to all the different epithelial cells and are considered self-renewing, long-lived, and multipotent stem cell. Between the intestinal stem cell and the Paneth cells are the position 4 cells, which are considered the so-called reserve cells, and these are been found to be highly resistant to radiation and are believed to be important for recovery from severe gut injury. Here we see a schemata of the GI epithelium. At the base, we have the LGR columnar stem cells, and we have the Paneth cells. And between the Paneth cells are again those reserve intestinal stem cells, and then intestinal stem cells differentiate into all the subsequent epithelial cells, and they migrate up the crypt, where they ultimately sloughed and go undergo self-renewal. Importantly, it's been very well established that the intestinal stem cell and their niche, including the Paneth cells, etc., is the target of acute GVHD. This is shown by researchers in Japan, Dr. Takashima, and Fu in China, and this helps to consider future considerations in the treatment of GVHD. So immune responses are critical for maintaining homeostasis of the intestinal environment and protecting against infection, toxins during host microorganism interactions. And cytokines primarily control the immune-related events and exert a wide range of immune regulatory effects through binding the cytokine receptors on the GI epithelial cells. The intestinal stem cells express multiple cytokine receptors, which determine their fate. So under the exposure of interferon gamma, interleukin 13, interleukin 17, and 22 and 10, the intestinal stem cells are driven towards differentiation and recovery of the epithelium. And the interactions between the intestinal stem cells and immune cells in respect to cytokines are very complex and dependent on dose, both the number of present immune cells and the cytokine concentrations, as well as the duration of exposure, which I'll show in the schemata. So importantly, we see here the intestinal stem cell, the columnar base cell. Fascinatingly, this stem cell can serve as antigen-presenting cell through MHC2 and CH2 pathways. It can engage T cells. And then under exposure to Th1, Th17, and Th2 T cells and their cytokines, interferon gamma, IL-17A, and IL-13, this promotes differentiation of the stem cells and recovery from injury. Whereas when regulatory T cells engage the intestinal stem cell and the appropriate cytokine IL-10, this promotes renewal of the intestinal stem cell and as opposed to differentiation. So CD4 and CD8 T cells are found in lamina propria and are thought to be derived from T cells that have been educated in secondary lymphoid organs. And short-term exposure of T cells and their cytokines, interferon gamma and TNF alpha, lead to early and sustained activation of AKT-mediated B-catin, which promotes intestinal stem cell differentiation into proliferative transitional cells and subsequent crypt cells. But under prolonged exposure to these T cells and their respective cytokines, actually, after prolonged exposure, the opposite occurs, where the intestinal stem cell undergoes doesn't undergo differentiation, but in fact undergoes apoptosis. And so here we see a schematic of acute GVHD, where infusion of T cells undergo in the graft undergo proliferation of cytotoxic T cells, where they then migrate to the gut through the MET-GAM axis pathway, and part of again as shown in the previous slides of intestinal stem cell. So quickly, future directions in treatment of gut GVHD for the dawn of time has been immune suppression with corticosteroids, calcineurin inhibitors, methotrexate, sirolimus, etc. Recently, JAK inhibitors are believed to be important immunosuppressive agents. Importantly, there is evidence that ruxolitinib actually impacts the intestinal stem cell compartment. It reduces response to those inflammatory cytokines that I mentioned. It inhibits interferon gamma signaling, and it protects against interferon gamma-induced apoptosis of the intestinal stem cell. It reduces loss of these intestinal stem cells, dependent cells, via increased regulatory T cells, at least in preclinical models. You mentioned that you use vedolizumab and inhibition of the alpha-4 beta-7 MET-GAM access and decreasing migration of these T cells to the gut is one strategy for treatment of acute GVHD as well as prevention. I'll share with you results of our work with vedolizumab and steroid-refractory acute GVHD. And there's an important recent study that will be coming out in Nature Medicine, where Ian Chen and colleagues at Mass General did a multi-center trial of vedolizumab for prevention of gut GVHD and showed very encouraging results in this randomized trial. In terms of tissue regeneration, this is an area of active research. Today we don't have time to dive too deep into it, but we completed trials with an important cytokine IL-22, which is important for regeneration, we believe, of the intestinal stem cell. And I can share with you reference for that very important study. There's work being looked at with glucagon-like peptide 2 or GLP agonists as a way to promote protection and recovery of intestinal stem cells. Other kinase inhibitors is an area of active research. As I mentioned, this was our multi-center trial of the important cytokine IL-22 treatment of patients with acute GVHD. Again, I don't have time to dive into this trial today, but I want to get to your questions. As I mentioned, glucagon-like peptide 2 is being studied, and here's the important reference for that. What about treatment of dysbiosis? Here at MD Anderson, we just completed a very important multi-center trial where we're giving prophylaxis with a tolerizing bacteria called E. infantis that's contained in infant guts, which has tolerogenic properties, and we give this along with its food source, human resin oligosaccharide, for the prevention of GI GVHD as well as other outcomes. Of course, fecal transplants is an area of study for the treatment of steroid-refractory acute GVHD. The largest work in this comes from pharmaceutical company, the French pharmaceutical company MAT Pharma, where they have a pooled FMT product, which they've done phase 2 trials with in the setting of steroid-refractory acute GVHD, and they've recently embarked upon a pivotal trial for ruxolitinib refractory patients getting a pooled FMT, and have preliminary very encouraging results with response rates approaching 50% in this high-risk population. Importantly, again, it's artificial to think about each of these different approaches as being separate from one another, because the immune system and immune cells play an important role in tissue repair and regeneration and under influence of the GI biome, and all these processes are interrelated. So in the last few moments, I want to review the questions that were provided to me in advance of today's talk. Again, I will give a very cursory response, and then I can take a deeper look at these, and I will share with you a more detailed response on the important papers offering why I support the response that I give to you guys, and I'll send it to Dr. Nikhil for you to forward along to the rest of your group. So one of the questions was, when do you label a patient ruxolitinib refractory? Well, there is not good data for how to define this population. There is consensus opinion. There's a publication in 2020 by my friend and colleague, Professor Moti in France, where they established a definition for rux refractory as patients who progression of GVHD after 5 to 10 days, as defined as increased grade or stage or new organ involvement, lack of response after 14 days of ruxolitinib, or a loss of response defined as progression or of stage or grade or new organ involvement after initially having response. Additionally, one could consider non-reversible toxicity or failure to achieve a complete response or very good partial response by day 28 as being consideration when consider patients who are ruxolitinib refractory. It sounds like you guys are a little bit more aggressive and start next line therapies early. Median time to response on the REACH 1 and 2 trials were between 7 and 10 days, with 60, a little better than 60% of the patients responding by day 14. But about a third of the patients took longer than 14 days to respond, as long as 2.5 months to respond to ruxolitinib. So I tend to give ruxolitinib a little bit longer. It's not to say I won't start next line therapy earlier than 14 days, but I often continue the ruxolitinib with understanding that as much as maybe a third of the patients may take upwards of a month or longer to get a response based on our phase 2 and 3 data. Any baseline factors which predict for a patient being refractory to steroids or high-risk patients? Well, of course, there's the revised Minnesota criteria where patients present with high-risk acute GVHD. This population represents about 15% of patients with newly diagnosed acute GVHD, and this is a validated clinical rating system that identifies this high-risk population as being those who present with stage 4 skin, stage 3 to 4 lower GVHD, or any isolated liver GVHD. If you have more than one organ involvement of acute GVHD, you're high risk, and of course, you have 3 organs involved, you're very high risk. The problem with the revised Minnesota criteria is that while it's very sensitive, these patients indeed are high risk. Many patients in the standard risk population are also high risk, and so it's not very specific. Sorry, it's specific, not very sensitive. At the Anderson, we've looked to try to improve that. What additional factors may predict for higher risk populations? Well, in multivariate analysis, we found the biggest predictors of high risk are any lower GI involvement. Patients over the age of 50 and those with high comorbidity index have worse response rates as well as much higher non-relapse mortality, and the presence of multiple of these factors further increases that risk. Back when I was a fellow, I was trained by one of the greats by the name of Rodinatha Therthorn, who did some of the pioneer work in GVHD prophylaxis, and he taught me at that time that you can identify patients who's high risk when they present with severe abdominal pain that's not associated with bowel movements. So patients who have GI GVHD often have cramping bowel movements, but these are patients who have pain in between bowel movements, and we now know that these patients are extremely high risk. In fact, that's one of the criteria for stage 4 low GI in the MAGIC consensus criteria. Patients with severe abdominal pain requiring IV narcotics, those patients independent of diarrhea have stage 4 disease. GI bleeding, he taught me, anybody who presents with bloody stools, of course, are high risk. And again, this has now become part of the stage 4 lower GI criteria per MAGIC. Mucus in the stool, or those who present with luminal gas, or you actually see sloughing at the mucosa, of course, those patients are very high risk. Any role of ethnicity, none that I'm aware of, but if you have data, it's worth looking at, then it would be important to understand if those are psychosocial or biologic, what would be the genetic behind the difference in terms of GVHD in response to therapies. What about role of biomarkers in early prediction of severe GVHD? Well, there's a wealth of data about upfront biomarkers, serum biomarkers, which have been validated to predict day 28 response as well as non-relapse mortality. The best data comes from the initially Ann Arbor group and later the MAGIC consortium. Work done in Minnesota was looked at anthracycline, and these have been validated predictors at the time of diagnosis. But in clinical practice, how do we interpret this and what do we do with information? Yes, the biomarkers can tell us for who will do bad, but there's no data that anything beyond steroids in upfront setting improves outcomes. So what do you do with that data remains an area of question. How do you sequence therapy in patients who are refractory to steroids and ruxolitinib? Well, sequencing therapy is an area of active research in steroid refractory chronic GVHD. Do you give steroids, then ruxo, and then belumosudil, or axatilimab, or which sequence should you go in terms of treatment of those populations? But in acute GVHD, sequencing of therapy is not really an area of research because A, we don't have much beyond ruxolitinib. We don't have a wealth of additional therapies which have been proven beneficial. And on top of that, the median survival after ruxolitinib failure is just 28 days, so there really is not time to really consider how to sequence therapy. What is your preferred third-line agent? Well, no one can cite a preferred third-line approach. Clinical trial, if you have one, is the way to go. But it really, when we're considering what to give beyond ruxolitinib, it depends on baseline toxicities. How does the patient's counts look? Do they have abnormal liver function tests? Are the kidneys working? What's their performance status? And so all that oftentimes comes into the fold for which agents we choose. Increasingly, we're getting away from traditional immunosuppressants and instead looking at ways to not add additional immunosuppression, but hopefully promote recovery of a severely injured gut. This would include drugs like alpha-1 antitrypsin, mesenchymal stem cells, vedolizumab, or alpha-4 beta-7 integrins, as you mentioned in your introduction, FMT. These are increasingly our therapies of choice. Occasionally, patients do respond to pentostatin in select patients, and I have a reference which I can review with you. And ECP is used this mainly in patients with refractory skin and liver, and the data for ECP in patients with lower GI GVHD, at least in adult, and very, very poor. And at our center, we do not use ECP for patients with lower GI GVHD. What are the expected, here's some data about alpha-1 antitrypsin. In the interest of time, I may not cover this, but again, I'll send these slides over and you guys can look a little bit deeper into it. We do have a multi-center trial, which I'm privileged to lead, along with my colleague John Mackinac at University of Michigan, looking at AAT for high risk acute GVHD. This is a randomized trial versus placebo. There is data for pentostatin, as I mentioned. In fact, in a very, very refractory population of patients who had half of them had stage 4 lower GI involvement. We looked at 60 patients treated with pentostatin. We saw a very promising response rate of 50% in this population, but responses were best in patients under the age of 60. And pentostatin, you have to be careful with counts. You have to be careful if their kidneys are not working. And I encourage you to read through this paper because we share some insightful information who may benefit from pentostatin. What are expected response rates once you get beyond ruxolitinib? Well, the data would suggest that beyond ruxolitinib, the expected response rate is in the order of 30 to 40%, with just 10% of those patients achieving a complete response. But even those who respond, non-relapse mortality is very high, as shown previously, median survival just 28 days. Organ-specific treatment for GVHD, do some agents work better? In general, some agents appear to work better for certain organs versus others, but apart from what I mentioned below, not really. We don't really think about it in that way. But of course, ECP, as I mentioned, we mainly have our center limited to those skin liver GVHD, mesenchymal stem cells. The previous phase 3 trial suggests it's most beneficial in patients with lower GI and maybe liver, not skin. Alpha-4 beta-7 integrins is GI specific, of course. FMT is considered GI specific therapy. ECT role and median number of sessions, expected response, how long to continue it. Well, our approach is to consider it for patients with steroid-refractory acute GVHD of skin and liver. We typically give 8 to 9 sessions through day 14, 6 sessions between days 15 to 28, and 8 sessions between 29 to 56. And this comes from the randomized phase 2 trial that I conducted in acute GVHD using ECP and has previously been published upon. And typically give ECP for a month before stopping it for lack of response. There's that paper that I mentioned. Again, I'll send these slides along. Role of FMT, how often, how long to continue it. We typically give one FMT, typically via enema, and a patient responds but receives broad-spectrum antibiotics. They think it's rational to give another treatment, but at our center, we typically just give FMT, we give it just once. In the MAT trial that I shared a little bit of data with, they give up to 3 FMTs. We don't know more is better. I would offer caution that you have to be careful when doing FMT. There have been case reports of fatal bacteremia infections with patients who receive products that contain multi-drug-resistant organisms. My colleague Dr. Philippe at Mass General, Jen, published in New England Journal of Medicine, important paper where they had fatal bacteremia and traced it back to the product received. And so screening your stool is very important, and there is best practices and published best practices for that screening. Again, the largest data for in the case for FMT comes from the Matt Pharma group out of France, and there's ongoing prospective trial on ruxolitinib failure patients, primarily done in France, and they've seen very encouraging results, maybe responses as high as 50% in this very high-risk population. Role for vedolizumab. The largest trial that I'm aware of for vedolizumab for steroid-refractory GVHD was a retrospective analysis that we published on here at Anderson. You can see the reference there. 21 patients with refractory lower GI GVHD were given vedolizumab. These patients had failed multiple lines of therapy with a median 3 prior lines of therapy, and we saw a response rate of about a third. In patients who were refractory to ruxolitinib, the response rate surprisingly was a little bit better. So I didn't know what to do with that data. And the patients who had previously received and continuing to receive ruxolitinib, the response rate to vedolizumab approached 50% at day 28. The drug was very well tolerated, but we don't give it to patients with abnormal, significantly abnormal LFTs based on packaged insert. Mesenchymal stem cells. We have the next topic. As far as mesenchymal stem cells, we are conducting a trial here at MD Anderson with mesenchymal stem cells for patients who are steroid refractory. We give mesenchymal stem cells right from the umbilical cords. This is a randomized trial of giving this combination to Ruxo at 2 different dose levels versus Ruxo alone. And this is mainly given for patients with refractory lower GI GVHD. And so far, the results have been very encouraging. Response rates higher than 50% have been seen. And of course, this is very well tolerated. So yes, we do give mesenchymal stem cells primarily within the context of a clinical trial. What about lithium? The data for lithium comes from publications out of the Fred Hutch, primarily by Paul Martin. The rationale for giving lithium is that it does, in preclinical models, appear to promote recovery of the intestinal stem cell via the Wnt signaling pathway. And so it did a small pilot study in patients who had advanced histologic GVHD of the lower gut. So these are patients with histologic grade 3 or 4, denuded bowel, and these patients historically do very poorly. Patients with histologic grade 4 may have non-biological mortality that approaches 80% and very poor response to steroids. In this small pilot trial done out of Fred Hutch, and they gave lithium, the response rate, combination of lithium with steroids and other agents, in this very high risk population approached 67%. The drug is not without toxicity. It does cause somnolence. It can affect counts and affect LFTs. We have some limited experience at MD Anderson. I haven't found it overwhelmingly successful. Occasionally, we will give it a try. What about Progenol? So this is urinary derived HCG coming from work on Sharon Holton at University of Minnesota. She's published on given this agent for steroid-refractory GVHD, and her results in her publication would suggest that this therapy offers some benefit. I would caution that she didn't use traditional definitions for response, and many of these patients received this therapy in combination with other therapies, including ruxolitinib. And so I've been cautious in the interpretation of that data. I provide some slides in the slides I forward along. I provide some data regarding those studies. Let's see what else we have here. How long you continue treatment? How do you taper? Typically, I give steroids 2 milligrams per kilogram for 10 to 14 days in non-responding patients before I taper. Why do I wait that long? Well, as I shared with you earlier, better than 50% of the patients may be slow responder to steroids, and I want to afford them the opportunity to respond. So unless I have to for clinical reasons, I continue steroids for at least 10 to 14 days before I begin to taper. But we do taper steroids when starting second-line therapy, and this is very important. We have an institutional pathway for tapering steroids when we begin second-line therapy, which generally calls for tapering the steroids rapidly by 25% every 4 to 5 days in the absence of deviation progression, and we taper it down until a minimum dose of about 15 to 25 milligrams of prednisone is achieved. And beyond steroid refractory, we have an institutional approach for tapering steroids in all patients, and this is somewhat based on organ manifestation and risk categories. Infection prophylaxis, of course, is important in steroid refractory acute GVHD. We give mold active azoles, we give Veltrex HSE, we give letermovir in CMV seropositive patients, and we give some form of PJP prophylaxis, be it Mepron, Etamidine, or Bactrim in those with platelets and kidney function. What about antibacterial prophylaxis, especially in patients with lower GI GVHD, patients who have acute GVHD, again, especially those lower GI GVHD are much higher rates for bloodstream infection, but there's no data that suggests that giving prophylactic antibacterials prevents these infections and may be detrimental with regard to the GI. In general, we avoid giving routine prophylaxis against bloodstream infections unless the patient is neutropenic, in which case we use Milums. We do aggressive screening for viral infections, including CMV, adenovirus, and EBV. We do weekly screening blood cultures, and we have low threshold getting baseline CT of chest for screening for fungal infections. Cytokine assays determine refractoriness. I briefly touched upon a little bit. What about when patients are steroid ruxolitinib refractory? Should you taper them off of therapy? My practice is generally to give ruxolitinib for at least 1 month, but we'll often start next-line therapy concurrently. Why do I give ruxolitinib for at least 1 month? Well, as I mentioned in the previous REACH 1 and 2 trials, while most patients did achieve a response by 14 days, about a third took much longer to respond, and if they're tolerating Ruxo, I do continue it. Any infections that are higher with certain approaches than others, such as CMV, well, it's impossible to compare across prospective and retrospective reports the risk for infections and compare therapies in that regard. But there are therapies that have been reported to result in high viral reactivation, including CMV. These therapies include, of course, ATG, antistatin, but importantly, anti-TNF agents have also been implicated to result in high rates of viral reactivation, including CMV. In the REACH-2 trial, comparing against best available therapy, CV rates did not appear to differ between the arms. I believe those were all your questions, and I really appreciate your attention. And I'd like to take any additional questions that time allows. We can forward more detailed responses to those questions you provided to me to deal. Looking forward to all you guys for your review. And this would include references and more deep dive into the responses of your very thoughtful questions. If you have any additional questions, here's my email address. Feel free to email me any questions you may have, and I look forward to future collaboration and hopefully meeting in person with your team. And again, thank you for inviting me.
Thank you, Dr. Alausi. That was an excellent talk. Considering we asked you to give this talk at the last minute at such short notice, you've prepared extensively. The way you explained the pathophysiology of GVHD and your approach, as well as the way you patiently answered all our questions, really wonderful. Enjoyed your talk. We have a couple of questions that have come from the audience. Shall I start with them?
Sure.
So, in patients who are on azole antifungal prophylaxis, do you reduce the dose of ruxolitinib?
Yeah, great question. There may be a drug interaction with azoles, including Pos and Vori. No, in general, we don't. We let toxicities when to reduce the dose.
Dr. Roy has a question. A 41-year-old male case of relapsed refractory angioimmunoblastic T-cell lymphoma underwent a mud transplant. On day plus 22 of transplant, patient developed fever, rash, and loose stools. Lower GI scopy as well as upper GI endoscopy diagnosis was grade 2 GVHD. However, the CMV immunostain also came out to be positive after 48 hours. So his question is, in the scenario where there's strong evidence of GVHD involving multiple organs, but the gut biopsy also shows a CMV IHC coming out to be positive, how do you treat these patients with current CMV infection and acute GVHD?
So I love this question. Thank you so much. It's a great question, and one that does require nuance. So for the past 20 years, I meet every week and review slides for acute GVHD and with my pathology colleagues, and it's not when you do IHC, it's not uncommon in populations to see IHC come back positive. If you open textbooks of pathology, they will tell you you cannot read GVHD in the presence of CMV infection on biopsies. In fact, that is not the case. So how do we interpret when we see CMV IHC? Well, number one, if it's just one positive cell here or there, the majority of what you're seeing is the change of GVHD. Your patient has GVHD. Of course, CMV and GVHD are not exclusive to each other. In fact, very well and commonly, CMV likes to colonize injured organs, including gut, and so concurrent GVHD is not uncommonly present. When we look at the slides, we look away from where we're seeing the CMV and we look for the changes of GHD, whether it be a different fragment from a different part of the gut or even on the same fragment away from the area where we're seeing the CMV. We can certainly look for the changes of GHD. How do we treat? Well, we treat both entities. I can tell you, as countless cases, I receive emails weekly from colleagues across the country and the world about how we treat such and such patient who has steroid-refractory GVHD. One of the most common pitfalls is when I see these patients. Patient came in with 2-3 liters of diarrhea. We thought it was C. diff. We thought it's CMV. We thought it was magnesia. We waited. It didn't get better. We thought it was the mycophenolate. We stopped the mycophenolate. Patients require treatment for GVHD, and more than likely the patient has infection plus GVHD rather than infection alone. As diarrhea, use treat with steroids. Of course, we'd use phosphorinet or ganciclovir if the counts allow. I would offer caution of using ruxolitinib currently with ganciclovir because of count suppression. If the kidneys allow, we would give phosphorinet. I hope I answered your question.
Yes, definitely. So you would go ahead with high-dose steroids and treat the CMV concurrently.
Absolutely. Importantly, another thing I meant to touch on is we commonly get repeat biopsies of the gut in patients who are refractory or responded to steroids, and we learn a lot of important information. Data suggests about 10 to 15% of times you will find current infection, mainly CMV, in those populations, even in the absence of viremia. And so that's one of the reasons we get repeat endoscopy in these populations. Additionally, sometimes we see the immune response. We see that the apoptosis and injury is stopped, but you just have ineffective regeneration of the mucosa. And our approach, whether right or wrong, in those patients, maybe if therapy is directed at recovery and healing the gut rather than further immune suppression. Whereas in a patient who had regenerative mucosa, but ongoing varicoses, we may lean a little bit more toward giving therapies like antistat and other immune suppressives. Additional questions?
A practical question from when a patient comes in with profuse diarrhea, how long do you wait before starting therapy? Because very often it's very hard in clinical practice to differentiate between infected diarrhea versus GVHD. So we do an infected workup first, and what is the latest that can really wait to start on steroids?
We never delay steroids in a patient presents with diarrhea. As soon as GVHD starts steroids, you could always stop them if it's 100% certain that the GVHD is caused by infections. I realize that maybe the infection profile in India may be different than it is in the United States. I still see no downside to starting the steroids. Again, majority of the times, even when infection is present, it's infection plus GVHD rather than infection alone. It's obviously from an immune biology perspective, not hard to rationalize that infection of the gut would lead to further recruitment of T cells and injury of the gut and promote a GVHD. And so we don't wait. Somebody presents with diarrhea, we admit them to steroids and we soak them. There's sometimes I get the question, does steroids change the way the histology looks under the microscope? Well, the GI mucosa tends to regenerate itself over 3 to 7 days, and I have seldom, if ever, seen a case where I thought steroids have changed or inhibited my ability to establish a diagnosis of GI-GVHD when we review those slides. So we wouldn't wait. We would start it. Never delay steroids in patients with diarrhea. This is a high-risk manifestation of GVHD.
I think that's a very strong message that should go out to all our audience, that we should start at the earliest in patients presenting with post-transplant diarrhea. Many of the patients with acute gut GVHD, at least a third of them tend to go into chronicity, especially with severe grade 3, grade 4. So are there any strategies that can prevent chronicity in these patients? Do you have any particular agents?
Yeah. So chronic, your question is patients with high-risk acute GVHD, that's a risk factor for development of progressive chronic GVHD, and can we do anything to prevent the development of chronic manifestations in somebody who responds from their acute GVHD but is now at risk for chronic? Well, there have been prophylactic strategies to prevent chronic GVHD. Of course, publications of giving rituximab late to prevent chronic GVHD, given the BTK inhibitors to prevent chronic GVHD. In those prospective trials, one of the interesting exclusion criteria were those with prior grade 3 to 4 acute GVHD, which limits the interpretation of those trials. But in general, I would say making the case for ruxolitinib and continuation of ruxolitinib certainly would be there. There is evidence that ruxolitinib as a prophylactic agent can prevent chronic GVHD when used in combination with other prophylactic agents. And so one rationale for continuing ruxolitinib as you taper steroids and other therapy would be that it may mitigate against development of chronic GVHD. But at this time, there's no evidence that I can offer for that other than trials where ruxolitinib was incorporated into a GVHD prophylaxis backbone, and those trials showed low rates of chronic GVHD.
One last question from our end before we wind up. It's very common to have a GVHD flare, especially when we taper steroids and solid. So how do you prevent GVHD flares? And on taper immunosuppression, if the patient has a flare, how do you treat that?
So a flare as you're coming off of steroids or ruxolitinib can be seen. Typically, if they've gotten successfully to a low dose of steroids or maybe stop their steroids and the flare occurs, I will transiently for a few days go up to 1 milligram per kilogram, followed by a rapid taper to a dose level just slightly higher than where the flare was achieved or seen. Let's say a patient flared at 5 milligrams prednisone. I'll give, and they weigh 60 kilograms. I'll give 2 or 3 days of 60, 40, 20, 10, and then hold them at 10 for a few weeks if they can tolerate it, and then try again at a slower pace. Unless they are flaring at very high doses of steroids, I wouldn't consider next line therapy in those patients. But if somebody's flaring at a half milligram or 1 milligram per kilogram of steroids, they're likely to be steroid resistant, and I would start whatever next line therapy is appropriate in those patients. And that's similar to what I would do in chronic GVHD as well.
Can GVHD have fever as a manifestation? And does the presence of fever make GVHD a less likely diagnosis?
Absolutely. So GVHD, especially in the early traditional post-engraftment period, can present as fever. Skin commonly will present with low-grade fevers, and I have seen in my clinical practice even patients present with high-grade fevers, and 2 or 3 days later develop a frank rash in the absence of any additional findings for infection. So absolutely, fevers can. Of course, you would never just attribute it to GVHD. Of course, you're going to work it up and evaluate the fevers, and if appropriate, start antibiotics and what have you. But 100% definitively, acute GVHD can present with fevers.
I think with that, we come to the end of questions in the chat box and from our end. Once again, Dr. Alausi, it was a pleasure interacting with you. The clarity of thought and the simplicity with which you answered all our questions, it was really wonderful. And I'm sure this session would go a long way in recognizing and treating GVHD more effectively in our routine clinical practice. Once again, thank you so much, Dr. Uday and Dr. Alausi, for joining us and sparing your time on this busy Friday morning.
Thank you, Nikhil. I am going to forward, as I mentioned, I really provided a lot of additional slides and references to the response to those questions. I'm going to forward those slides to you, Nikhil, and I'll leave it up to you to send along to your colleagues. And then if there's further questions, my email is here. Feel free to head a low threshold. I never mind getting an email question about a patient or just a question you may have about GVHD, and I really enjoyed this session. Thank you so much, and thank you again, Uday, for inviting me to the session.
Thank you, Amin. That was a fantastic talk. Fantastic, really.
Thank you so much. That would be great. I'll definitely share it with my colleagues. And thank you, Dr. Uday and Dr. Alausi. We hope that we can have more such educational and interactive sessions in the future. Before we wind up, I would also like to thank Emcure Pharmaceuticals for organizing this and providing the backend support. It was a very smooth session and there was no hiccups in between. The session was very well organized. I also thank each and every one of you who has logged in on this Friday evening from India and all the other countries, with more than 300 participants all over the world who effectively participate in this. Thank you one and all, and we continue with educational webinars next month. Thank you so much. Thank you. Bye-bye.
Nilo, we can stop recording now.
Okay, ma'am.
Recording stopped. Thank you everyone for joining in.